Bismillah ar-Rahman ar-Rahim. Assalamu alaikum and good afternoon, everyone. My special thanks to Professor Jawad, Dr. Chima, and Noman Bashir for organizing this Chess Society conference and giving us this opportunity to talk. Today my talk is on how to treat pneumonia, especially in this era of antibiotic resistance, which is a big challenge all over the world in these days. And how to combat this resistance problem, how to come over this problem. So this is a long topic, the time is very short. We'll be very precise on a few points. Now, respiratory tract infection is a major cause of morbidity and mortality all over the world, and we need effective treatment. And the effective treatment is threatened at the moment, but the resistance we are coming across in almost all pathogens we deal with. So what we need to do, we need a new antibiotics, we need the new formulation of proven antibiotics, and a new concept of antibiotic. How to deal the infection in this era of resistance. We need all these things. Now we all know there are certain basic slides which we show to our PG, but they are very important in one aspect. When you want to treat the pneumonia, you always treat empirically initially, and that makes a very big difference. So the common, we know that respiratory infection still stands in the first top 10 mortality, and stands number 3 after ischemic heart disease and stroke. Now, the pneumonia is so complicated over the years that so many guidelines have been formulated. We have got Canadian guidelines, we've got infectious disease, Society of America, we have got American Thoracic Society, we've got European Research Society guidelines, and then we've got the combined guidelines, how to treat pneumonia. Now this is what to emphasize, that so many changes have been occurring over the years. Now, when we want to treat the pneumonia as empirically, the first knowledge of the clinician should be what type of bacteria we are dealing with. We know the source of infection, very basic slide, because the treatment is empirical, and we don't have the culture sensitivity result by the time we start the antibiotic. Normally we get the infection from aspiration, and every one of us aspirate when we sleep. But either our defensive mechanism is so up to date, or the dose of inhalation is so small, it does not result into the pneumonia. But if there is an imbalance between the two, either the dose is big, like the patient is very debilitated, old, aspirate, after anesthesia, drowsy, after stroke, or if the patient has got underlying lung problem, like structural lung disease, fibrotic lung disease, then the same dose of aspiration will result into the pneumonia. So in that setting, we should know what are the type of bacteria we are dealing with. So the common bacteria which we harbor in our mouth, they are either the H. influenza, Staphylococcus aureus, or anaerobes. But if a patient gets pneumonia and he is sick for something else, like UTI, he is a boil on the foot, or he is something else, and he gets septicemia resulting into the pneumonia, so in that setting we should have some idea what type of bacteria we are dealing here with the pneumonia. And the third, the commonest way we get pneumonia is the aerosol inhalation, and the commonest example is tuberculosis and viral diseases. Now when someone gets infection, the commonest way he presents with is the cough, the sputum, the chest pain, the temperature, the fever, and the new signs appear on the X-ray, and he gets the infection somewhere outside the hospital. We categorize and we label the patient has got community-acquired pneumonia. The chest X-ray in the GP is not mandatory. Now how common is it? Is somewhere 10 cases per 100,000 population. It involves the major cost, and the mortality is very high. I mean, 60% people who are admitted to the hospital, they get pneumonia one way or the other. And 5% of the people, all over the people admitted to the hospital, they get pneumonia. So the mortality is somewhere 10%, but it reaches to 40% if the patient is very sick in ICU. Now, some other factors has to be kept in our mind when we want to treat the pneumonia, that we know all this, that the causative agent cannot be accurately predicted. especially in this part of the world where we don't have the local surveillance data of the bacteria. And the people who are old, they do not present with the classical symptoms of pneumonia. With the non-specific symptoms, they usually present. And we all know that the X-ray changes lag behind. This is just a summary of the common organism we come across. Still the commonest bacteria, Streptococcus pneumo, followed by the H. influenza, Moraxella, and then the atypical bacteria. I will come to the proper topic in a minute in the next few slides, but we do get the MAX infection at the same time. The incidence of MAX infection is not clear. We need a proper data. Now this is a slide that 6,000 people from 10 European countries, the causative organism, still the Streptococcus pneumo number 1, followed by the atypical and viral, but this is the European data. Now, when someone comes with infection, what investigation we have to do? Probably none if we see as a GP clinic, but if we admit the patient, we go for the basic investigation, like chest X-ray, full blood count, urea electrolyte, and arterial blood gases. The blood culture as a routine is not recommended, but if the patient is very sick, we always send the blood culture, because if the patient has got septicemia, mortality goes very high. Sputum gram staining at certain stages, Legionella and urine antigen, even you suspect the patient has got atypical bacteria, and pneumococcal urine antigen, usually it is used in research purposes. We do not do the routine investigation, not recommended. But if someone has got pleural effusion, then one of the best tests to investigate and find the cause, you aspirate, set for differential count, and you get a lot of information. Chest X-ray, a very basic test, very good in differentiating pneumonia from other conditions which mimic pneumonia, like the pneumonitis. It tells the severity of the illness if the patient has got the multilobar and bilateral involvement, and it also detects the complication of pneumonia, like impneumothoraces, pleural effusion, or pneumothorax. Now, when we treat the pneumonia, certain other modifying factors had to be kept in mind. Like, if the patient is old and he has used the beta-lactam antibiotic in the past 2 to 3 months, he's got comorbid morbidities, and if he is immunosuppressed, then the chances of Streptococcus pneumo resistant to the penicillins are high. Pseudomonas, if the patient has got underlying lung problem, like bronchiectasis, he's got a fibrotic lung disease, then he's got the higher chances that his underlying bacteria might be Pseudomonas. And if especially the patient is immunosuppressed and he is on steroid at least 10 milligram per day, malnourished, or if he has used the antibiotics in the last 7 days, a recent hospital stay, which makes the chances of Pseudomonas high. Now coming to the crunch question. When you want to treat the pneumonia, how to use the antibiotic? This is the one we will concentrate slightly. Now, we don't know which approach is better. We need a well-designed prospective study in this area. What is the pattern of bacteria? What is the resistance of bacteria? And only that thing will decide which antibiotic do you have to embark on when you want to treat the pneumonia. We also do keep in our mind that the atypical infection also is there. Now, antibiotic resistance is a top concern all over the world. Virtually all important bacteria in the United States and worldwide are becoming resistant. And that's why the antibiotic resistance is called one of the world's most pressing health problem. Now, the type of resistance we come across is penicillin resistance. We have got the macrolide resistance. We have the production of beta-lactamase making the bacteria resistant. And fourth is the cross resistance. These are the common resistance we come across. Now, what is the implication of the resistance? If the bacteria is resistant, then it increases the delay in the treatment, increases the failure rate, and at the end, it increases the mortality and morbidity. Now, the penicillin and macrolide resistance is worldwide, but it's so variable because antibiotic resistance is usually driven by the amount of antibiotic used in their community. If you look for the penicillin and macrolide resistance, is very high in countries like Japan, but less in some of the countries like Canada. But it is high in those countries where the antibiotic is used very often. Second is, if you look for this PROTECT study, which tells us the multi-drug resistance of Streptococcus pneumo, it is high in Hong Kong, Taiwan, and South Korea, but slightly less in the European countries and Canada, where the antibiotic use is very judicial. Now, the only study in which the Pakistan was included to look for the resistant pattern, and that is the production of beta-lactamase and influenza. And this study was conducted by the SOURCE study, which was including the Pakistan and the Middle East, and they found out that 950 isolate of streptopneumo, 650 isolate of H. influenza, and 200 isolate of streptopyogenes. And the incidence of beta-lactamase production was very high in Senegal and Algeria, followed by some of the Middle East countries like Qatar and UAE, but the incidence in this part of the world was approximately 5%. So we are slightly lucky in this one. But one thing we know, that the resistance, whether it's a resistance to the penicillin or the production of beta-lactamase, over the year did increase all over the world, if you look on this one. And it goes side by side. We all know that the bacteria like Moraxella, more than 90% produce beta-lactamase, which decreases the efficacy against the beta-lactam antibiotics. But what is more important, and we as a clinician always ignore, that if a bacteria is resistant to the penicillin, then he has got a very high resistance, cross-resistant to the antibiotics. Now this is a slide showing, if you look for the incidence of the cross-resistance, then the Streptococcus pneumo resistant to the penicillin has got a very high resistance to the other antibiotics like beta-lactam, cefuroxime, almost 90%, but almost 80% to the macrolide. So the problem is not only the resistance to the penicillin, it's a very high cross-resistance, which makes it difficult treatment. Now how to reduce the resistance? Now how to control the antibiotic resistance? We have got 3 measures. Number 1, we reduce the colonization and infection. Second is reduce the use of antibiotic. And third is, if we want to use the antibiotic, we use the right drug in the right dose for the right duration. This is purely in the clinician hands. Now, how to reduce the production use of antibiotic? Antibiotic resistance is driven by the antibiotic use. In UK, more than 80% antibiotics occur in community quiet. But the pattern of antibiotic use that is totally different what we come across in this part of the world. If you look in the UK, in the GRACE study, 3,500 people in different countries, 1/3 had coamoxicillin, amoxicillin, 1/3 had a macrolide, and less than 5% had a use of quinolones and cephalosporin. Now this is totally different than what we come across. Now how do you decrease the use of antibiotic? We should not use the antibiotic for the simple cough and cold unless we've got the evidence of bacterial infection. Number 2, antibiotics should not be routinely used for the symptom of acute otitis media or sinusitis, and a 3-day treatment is sufficient in a lady who has got uncomplicated cystitis. Now, reducing the volume of antibiotic is very important. As I said, we do not use the antibiotic for surgical prophylaxis. Antibiotic use should be started immediately in suspected infection, but we discontinue the antibiotic as soon as the evidence is available. This is not bacterial. Now, this is the third aspect, how to control the resistance, is this one. When the decision you make to treat the infection, you use the right drug in the right dose for the right duration. This is purely in the hand of clinician. How we are going to do this one? We all know that the WHO statement that the most effective strategy against resistance is you unequivocally destroy the microbes before they develop the resistance. and we have got the expert opinion all over the world, that if you use the higher doses for the last two slides, if you use the higher doses for the shorter duration, it decreases the resistance. This is the expert opinion all over the world. Then, if your diagnosis, the diagnostic, if your patient is not responding to your treatment, you review the diagnosis, exclude the underlying condition like congestive cardiac failure, pulmonary embolism, and you always exclude the pulmonary complication like empyema-thoracis, and think of TB in this part of the world. But if your diagnosis is correct and still the patient does not respond, you always exclude obstruction, foreign body, empyema. Among the drug, the error is the selection, the dose, and drug interaction has to be ruled out. And the third one is the pathogens. It's a non-bacterial, look for the TB, the viruses, the atypical bacteria. But if it's a bacteria, then the resistance need to be addressed. It might be resistance. So in conclusion, empiric treatment for community cardiopneumonia remains a challenge. The role of atypical bacteria is unclear. A number of differences still exist between the American and European guidelines. We need a local prospective data to find what is the best strategy. And we all know smoking increases the mortality from pneumonia. And the last slide, Alexander Fleming in 1945 said that the greatest danger when the people will consume antibiotics too often and too low doses, then instead of eradicating the bacteria, going to breed out the host of organism which is resistant to the penicillin, and we will no longer able to treat the pneumonia with the penicillin. Thank you.